Well, we'd like to thank you for being here today, and we're looking forward to hearing your presentation.
Thank you for inviting me. So, how did I become interested in kidney transplantation in children and subsequently pursue a career in pediatric nephrology? Well, in July 1966, I joined the Division of Metabolic and Renal Disease at Children's Hospital, and I was an instructor at USC. And I had no interest in kidney disease. I was interested in metabolic diseases. But in September of that year, a few months later, a 6-year-old boy was referred to me with renal failure, and a biopsy revealed he had end-stage renal disease. There was no hemodialysis available at Children's at the time, and I used peritoneal dialysis to treat him. And it was the old type of peritoneal dialysis where you put a catheter in and it lasted for about 3 days. You took it out and maybe a week or two later, you could do it again. And I sought availability of other institutions. And there was no institution in this country, and I don't think there was one any place in the world that had a program for dialysis and transplantation in children. So there were a group of surgeons who had done 1 or 2 transplants at either Mount Sinai or Cedars, and there were 2 different hospitals at the time. And they said they would come to Children's to transplant this young man with his father's kidney. Well, you can imagine there was a lot of discussion among the faculty at Children's as to whether this was a good idea. And after a lot of discussions, the decision was made to go ahead and transplant this young boy at Children's. But the proviso was that I learned how to do hemodialysis and take care of post-transplant patients. So in February of 1967, which is 50 some years ago, 56 years ago, this young man received a live related donor kidney from his father. And a few months later, I went to Mount Sinai Hospital in the hemodialysis, home dialysis training center, and spent a month there learning how to do hemodialysis, and embarked upon a career as a pediatric nephrologist. My training in pediatric nephrology essentially at that time was what I had learned as a resident and the month of training at Mount Sinai in hemodialysis. We hemodialyzed one of our first patients, and in December 1967, we did our first transplant with the surgical team at Children's. And this is the young boy. A few months after we transplanted him, you see, we placed the kidney intra-abdominally because they were afraid to put it extraperitoneally. It's the first time they did a child this young. And here he is about 10 years later. The only medication he was on was 5 milligrams of prednisone, 50 milligrams of Imuran, and ultimately 100. And here he is about 10 years ago with me. His kidney from his father lasted for 53 years. And about 2 years ago, he had to go back. He went on dialysis. He'd never been on hemodialysis. And he lives in Las Vegas. So when we started the program in the late 1960s, what were the prevailing opinions regarding the utilization of dialysis and transplantation for children? Well, Conrad Riley, who was a head of pediatrics at Colorado and had some experience with some transplants that Tom Startzel had done, said that if all goes well in the long run, the kidney may be housed in a healthy dwarf. And all the discomfort factors make the picture sound very bleak. And he proffered from the point of view of the child or even adolescent, how he knew that, I don't know, that these negative factors could well outweigh a small, in his opinion, extension of life. And about 6 or 7 years later, 3 years after we had started the program at Children's, John Reinhardt, he was a psychiatrist at Pittsburgh Children's. And he said that the cost to the child in terms of physical and emotional discomfort is considered. I seriously doubt the value of a chronic dialysis or renal transplantation for these patients. And he ended with, God grant us serenity to accept the things we cannot change, the courage to change the things we can, and the wisdom to know the difference. This was his doctor's dilemma. Well, Barbara Korsch, who was a head of pediatrics, general pediatrics at Children's for many years, was an expert and did much research in doctor-patient relationship, and also child development. When I started the program in 1967 at Children's, I asked her to gather a team of psychosocial support so that she could help me find out how to best manage these patients, because at that time, there was no roadmap. I had no idea what the problems were I was going to run into with regard to psychosocial development and psychosocial problems. So when Dr. Reinhardt wrote this editorial, we responded that diseases desperate grown by desperate appliance are relieved, or not at all. I must say it was Dr. Korsch's quote from Hamlet, not mine. So what was the immunosuppressive regime that we initially utilized? This was a paper I wrote after 3 years of the program, and we used pretty high doses of daily prednisone. We tried to lower it to lower daily doses of a year, and azathioprine in a relatively standard dose with some reduction if there was kidney function impairment. But our initial experience was woefully inadequate. You can see that it was a third transplant. The initial attrition rate in the first 6 months was more than 50%. With the second, it was about 70%. But with the first, we still lost about 80 kidneys in the first 6 months. And by 5 years, less than 50%, whether it was first, second, or third. So our initial experience compared to what the outcomes are today was relatively dismal. And if we look what's happened over time, as those of you who are involved in transplantation know, what's happened is that, I don't think you can see the color, so I'll try to move it over here, that we've eliminated cyclosporin over the past 20-some years, and tacrolimus is now the major immunosuppressive drug we use, along with the elimination of azathioprine, which is the blue line, and we now use mycophenolate. So the standard treatment today in pediatrics is azathioprine and Celsep and tacrolimus. Fortunately, we've started to reduce the amount of prednisone we use. And there are many programs that either only use prednisone for the first few days post-transplant or no prednisone at all. And I think that this has been a marked improvement in the management of these patients. So has the incidence of steroid use at the time of transplantation changed in children in the past 2 decades? Well, this study showed that in the late 1980s, it was between close to 95% of the children got steroids, whereas in the early part of this century, it was down to 65%. And probably today, it's probably considerably less than 25% of patients, children, get steroids. So one of the significant lessons I learned from the first patient was no matter how innocuous the drugs used for immunosuppression may appear, the long-term consequences may be severe. We knew what the effects were of steroids, and azathioprine was supposed to be a relatively innocuous immunosuppressive drug. And it took 36 years for the devastating impact of ultraviolet light and azathioprine to manifest the initial skin cancer in this patient, with a myriad of subsequent skin cancers occurring. So he had no cancer for 36 years. And then he started having a number of cancers. Now, one of the problems was he lived in Las Vegas, and a lot of ultraviolet light there probably contributed to the problem. But if you see, he had a transplant in 67. He was very active because in soccer, he lost a spleen in one of his testicles to trauma. But you see, in 2003, 36 years later, he started having squamous cell and basal cell carcinoma, even melanoma, et cetera, et cetera. Subsequently, I was able to contact a colleague at UCLA who was an adult, a transplant surgeon, a transplant nephrologist, and we switched his azathioprine to an mTOR inhibitor, and this has helped him avoid subsequent ones. But the fact that he had multiple cancers raised the question is whether this patient actually was tolerant, as manifested by the fact that he had these multiple cancers. The problem was, and that we could have maybe either significantly reduced or eliminated immunosuppression at some time. For those of you who are unfamiliar with the intolerance, the overriding term is immunologic tolerance, where you are unresponsive to just a specific donor from the get-go. Whereas operational tolerance is you have long-term acceptance of the graft after you discontinue immunosuppression. And there is an enormous amount of research over the past decade or two in trying to bring operational tolerance to clinical transplantation. And the one successful area is in pediatric live-related allograft recipients. Now, you know, the liver is not like the kidney. Unfortunately, you take the kidney out, it's gone forever. Whereas in the liver, you take a piece of the liver, it regenerates. So this was a group of about 20 pediatric live-related donor recipients of a liver from a parent. They almost all of them had biliary atresia. And they were all around 5 years or so post-transplant. They all got transplants very early in life, the first year or two. And they, if you can see, the blue part here is over a 6-month period, they tapered off all their immunosuppression. And here they followed the patients. These patients have now been followed for some between 15 and 20 years off all medication. And initially they were successful in 12 of the 20, 60%. And when they weren't successful because either clinically or by biopsy, they had evidence of rejection, if they were treated, it resolved and there was no lasting adverse impact. Unfortunately, this has not been success. This concept has yet to be uniformly successful, especially in children. And the major obstacle that impedes this clinical operational tolerance in solid organ transplantation is the absence of some biomarker. If I had a biomarker in that patient I showed you 30, 40 years ago, that would tell me, hey, he is operationally tolerant, I would have known to maybe proceed to try to taper his medication and avoid some of the complications with regard to basal cell and squamous cell carcinoma that impacted on him. But unfortunately, there was no biomarker that I knew of then, and to my knowledge, there still isn't. So despite reduction, as I'll show you, in the incidence of acute rejection, which is less than 15% in the first year, and the excellent one-year graft survival rates, which are 95% now compared to what I showed you, there continues to be a long-term attrition. So graft survival rate continues to slowly deteriorate. And these are data from a registry called NAPRATIX that involves North America and some countries in Central America. And you can see in the late 1980s, the living-related donor, 50% had a rejection episode, compared to 10 years ago, less than 10%. And more striking, 2/3 of the patients 25, 30 years ago had a rejection in the first year, whereas today it was only, excuse me for 1 second.
From wireless tower.
Okay, excuse me. I'm giving a lecture, okay?
Wireless tower.
I'll call you back. Only it's gone from 2/3 to less than 14%. And if you look at the graft survival rates, they've increased also the 1 year dramatically in living related as well as deceased donor. They're almost the same at 1 year. But if you look at the 5 year, there's still an attrition rate. And I think that's the issue that we really need to work on, why this is so. So here's some data, comparative data over different time intervals, showing that we're much better now than we were in the late 1980s, early 1990s. The 1 year survival rate was terrific, but there was still attrition. And if you look at the latest period, there's still this attrition. And that's what we need to work on. So what are the potential mechanisms as to why grafts continue to decrease longevity? Well, there may be some immunologic reasons, and there may be some non-immunologic reasons. The immunologic reasons are maybe we're not giving enough immunosuppression, or maybe we've given too much immunosuppression, so whatever may affect tolerance is abrogated. But the big issue, I think, is non-adherence. And I'll talk about this in a moment. And then there are a lot of non-immunologic. One big one, and why people are trying to reduce the calcineurin inhibitor dosage, is calcineurin toxicity, which can damage the kidneys. There are some diseases of the kidney that recur, and to date, some of them that we haven't been able to stop from recurring. There's a lot of nephrotoxic drugs that we may also give patients that contribute to the decrease in longevity, as well as hypertension, which we know affects native kidneys as well as transplanted ones. But one major area that really hasn't been addressed as much as it should is nephron underdosing. That yes, we're only giving them one kidney, and maybe we're not giving them enough nephrons. And there's a million nephrons in each kidney. But there are a lot of factors that impact on the development of the number of nephrons. And somebody can have the same creatinine and have 200,000 nephrons and have 1.5 million nephrons. And the problem is we don't know how many nephrons we're giving somebody because there's no easy way to measure at the moment. The only way you can measure the number of nephrons is take the whole kidney, and there's a method called the fractionated method where it takes about 18 hours and you count all of the nephrons, but that's it. So one of the things in the future, and there are some methodologies that may involve to be able to tell how many nephrons there are. And one of the things in the future maybe we need to do is make sure if we're going to transplant somebody, we give them enough nephrons, because we all get all of our nephrons by 34 or 36 weeks gestation. And the rest of our life, the only thing we do is lose them. So depending on what kind of kidney one gets, the creatinine may be okay, but the number of nephrons may vary substantively, and any loss can have a non-immunologic impact on kidney function. And it's my feeling that the most significant two factors that contribute to attrition are, one, non-adherence. And some people have felt that as high as 40 to 60% of grafts that are lost long-term are because people stop their medication. And the other issue, as I pointed out, may be we just don't give them enough nephrons at the beginning, and they're all going to lose some, but if they don't have enough at the beginning, the more that they lose, the ones that remain accelerate in becoming sclerotic. What about non-adherence? Well, the first report in children about non-adherence was by Barbara Korsch and I about 10 years after our program. And at that time, of 80 patients we had transplanted, 14 of them, or almost 20%, had non-adherence. How do we detect the non-adherence? Well, the patients came to clinic, their cushingoid facies decreased, they lost weight, and their kidney function deteriorated. But all of these patients were ultimately identified because they talked to the members of the psychosocial team and told them that they were non-adherent. And the devastating factor is that 8 of the 14 lost their grafts, and 6 of the remaining 14 had a permanent impairment of kidney function. And of those that lost the graft, we transplanted, I think, 5 or 6 of them after a lot of psychosocial support from the psychologist, the social worker, etc., who was working with us. Still, on the second transplant, half of them stopped their medication. And we really couldn't delineate what the factors were that motivated non-adherence. Maybe fatherless households, family disequilibrium. Bob Nevins, who's a pediatric nephrologist at Minnesota, and Amanda Du, who's a psychologist at Pittsburgh, wrote this paper about 3 years ago, which said, where are we today with non-adherence? And basically what the paper said was, after more than 40 years of the publication I showed you, delineating the devastating effects of non-adherence, the identification of the non-adherent recipients and approaches to prevention are still very inadequate. And there have been a lot of different studies. We do a better job today in identifying the non-adherent patient because we have blood levels of drugs, which we didn't have in the past. And with blood levels done frequently, we're being able to make the diagnosis earlier. But the big problem is that we really need to make a diagnosis of non-adherence in real time. Why? Because in real time, as soon as they stop the drug, there's damage. They come to clinic 2-3 months later, the damage is already done. So are there any interventions that have proven effective in non-adherence prevention? And the data in the literature indicates that there's been a lot of intervention strategies, but none has been as effective as we'd like. So the failure to identify non-adherence in real time, as I've said, and initiate immediate correction with continuous monitoring is the biggest impediment to avoiding non-adherent destruction of grafts. Maybe there's something on the horizon to detect adherence real time. And about 3 years ago, a very important medical journal called the New York Times reported that the FDA had approved a psychiatric drug, Abilify, for putting an embedded sensor that, when it came in contact with the stomach, generated an electronic signal, and there was a patch worn where that signal went to. It couldn't go directly to someplace else because of the obesity of our patients, but it could go to a rib cage, a monitor, and then from there go to a database. And the patch, sends the time and date when the pill was ingested, and if it's not there, then the physician can be notified. I think this is a good idea, but it's still a problem, because if you can't go directly from the stomach to the caregiver, we're in trouble, because you're relying on somebody changing that patch and putting the patch on, and I'm not sanguine that that's going to be foolproof. With regard to nephron number, Barry Brenner, many years ago, felt that nephron underdosing may contribute to chronic allograft nephropathy. And the concept is, if you don't have enough nephrons, and a lot of it is low birth weight, prematurity, other reasons, those that remain hyperfilter to maintain a normal GFR. And in hyperfiltering, you develop glomerulosclerosis and impairment of kidney function. So this is the concept of not enough numbers ultimately causing trouble. So as you know, 50% or more of the transplants in pediatrics are from living donors. But about 12, 15 years ago, UNOS decided that pediatric patients should be advantaged, and they developed guidelines to give priority to pediatric patients. And now a lot of pediatric patients are transplanted within 6 months of dialysis. Because of this, the numbers of living donors are decreasing. You can see this green line here. Since starting in about 2007, when the new guidelines came in, the numbers of live-related donors decreased. What happened was that for the decrease, there was an increase in deceased donors, so the overall number of pediatric transplants stayed the same. So is there any long-term consequences to having one kidney? If somebody's going to give a kidney, the general feeling in the past has been there's no deleterious long-term effects. And unfortunately, most of the papers prior to about 8 or 9 years ago were written by our colleagues in the surgical colleagues in transplantation. And they compared outcome to the general population. But the outcome really of transplantation with one kidney needs to be compared to eligible donors, because the general population with obesity, smoking, it's hypertension, etc., is not comparable to the eligible donors. And about 7-8 years ago, this paper from Norway looked at over 2,000, close to 2,000 donors over a 45-year period. And what they were able to do, since they have a wonderful registry of everybody in the country, they compared it over time to almost 33,000 eligible donors. They had the same characteristics as a donor. And the bottom line is there were 9 of almost 2,000 compared to 22 of almost 33,000. And what that showed is the donors had an instance of end-stage renal disease of over 300 per 100,000 compared to the appropriate control comparator, only 100. So this has changed the playing field dramatically. Now, when people are, there is discussion about live-related donation, one needs to say, yeah, there is an increased risk to having one kidney, albeit somewhat small, but it's there. And if you look in these data, the all-cause mortality for the donors was higher than their eligible controls. So this information, I think, has changed, and there's a lot of guidelines that have now been developed so that potential donors are given the appropriate information. Albeit the risk is not that great, but it's not nothing, and it's not what had been told to donors in the past. Therefore, the risk is small, it's not innocuous. And if we continue to utilize live donors, it's really imperative that these donors should be given lifetime insurance, and that lifetime insurance is contingent upon an annual physical. And we'll have over the next 50 years the kind of data we need to really tell donors in this country what the risks are. We should have done this in 1973 when the federal government decided to approve Medicare for end-stage renal disease, but no one pushed them at that time. And I think that's why we don't have really comparable data in this country to what they had in Norway. But despite any limitations as with regard to longevity, there's no question that transplantation is the best therapeutic modality for end-stage disease. These are data a few years ago, but if you can see the longevity for dialysis, depending on age, versus longevity for transplant, much better, but still less than we'd like to see with respect to the general population. So we have a ways to go. And this is just the previous data shows that transplant, you can see the 5-year mortality rate is less than 95%, whereas hemodialysis, it's about 80%. This is not children. Finally, the most significant advances I've witnessed over the past 50 years have involved the emergence of erythropoietin stimulating agents, the use of growth hormone for growth retardation, and the new drugs that we can use for renal osteodystrophy. When I was at UCLA in the 80s, we did a pilot study, which was the first pilot study that was ever done in children, and it was the first time ever that subcutaneous erythropoietin was used, because prior to that time it was all IV for patients on hemo. And we had 5 patients undergoing peritoneal dialysis, 12 to 18 years of age. And after 3 weeks, their hematocrits increased from 22 to 33, and they didn't need any more transfusions. Unfortunately, prior to that time, patients undergoing any form of dialysis, we let the hematocrits go down to 11, because if we thought we made them hypoxic enough that it would stimulate erythropoietin production and red blood cell production. It was very ineffective. Now you can see, these are data again from the NAPRTX registry. The blue line is patients coming to transplant who've never had a transfusion, and now it exceeds 80%. As I showed you initially, growth retardation was an onerous facet of chronic renal disease in children. And the advisability of starting dialysis was questioned because of the growth retardation. And some of you know my wife, Shawnee, who worked with me for many years. She was about 5'4" here, 5'4", 5'5". And this is one of our patients who was on dialysis. And here is the patient post-transplant with his buddies. And you can see that these patients' adult height was severely impacted. And over the past more than quarter century, the patients usually were transplanted when they were quite short. Now they're almost at the 25th percentile. It's made a marked difference. And the difference has been that now the average adult height is about the 25th percentile, not around the 3rd to 5th percentile. And there was a pilot study that we did with growth hormone when I was at UCLA in the mid-1980s, where we treated patients on dialysis, post-transplant, and with chronic kidney disease. And this was the first child who ever got growth hormone post-transplant. He was about 15 years of age. And he was on alternate day steroids, but even so, you can see he's got some cushingoid facies. Here we transplanted him at 7, and then at 15, you could see his growth spurt started to fall further away. We treated him here with growth hormone, and here he is about 2 or 3 years later. The cushingoid facies, nothing else changed, stayed the same, and he grew and slimmed out. And this is a little boy who's about maybe 9 here. It's his 7-year-old brother. And when he's maybe 11 and his 9-year-old brother, he's still shorter, not so happy. And here he is, we dialyzed him at age 4, transplanted him at age 8. And then when he was about 11 or 12, we gave him growth hormone, and he got up to the 5th centile. His mother was Hispanic and his father was Filipino, and his mid-parental height was somewhere around the 5th percentile. But now, after growth hormone, he's taller than his younger brother, and now he's smiling again. And lastly, one of the most important lessons I've learned over the past 50 years was humility. But it took me more than 40 years to learn that lesson. How did I learn it? This was the first young lady that the team at Children's ever transplanted in December 1967. And about a year and a half post-transplant, she was 14 when we transplanted her, she came to clinic and said, "Dr. Fine, I think I'm pregnant." Her relationship, there was no special relationship with the father. And I encouraged her to not have this baby. Why? Because in 1969, 1970, we had very little data, if any, on what the outcome was in adolescent pediatric renal transplant recipients, and had very little data on what the long-term outcomes were of multiple transplants. But she wasn't about to listen to me. She wanted to have this baby. And indeed, as you can see, she did. And this is the patient with her daughter, I guess was close to 8 or 9 at the time. And I took care of the patient until 1991, when I left UCLA for Stony Brook to become chair of the department. I transferred her care to an adult nephrologist. And somewhere in the late 1990s, I got an email from her. It said, Dr. Fine, they tell me the kidney is not working so well. This was about 30 years post-transplant. And they say I may have to go back on dialysis. And then I didn't hear from her until, well, when I was dean of the medical school, somewhere around 2006, I got another email from her. And she said, Dr. Fine, you know, I had to go back on dialysis around 2003, 2004. But I got another kidney about 2-3 years ago, and it's working perfectly well. So you tell me where the kidney came from. From the daughter, who I told her would be a good idea for her not to have. So that taught me a little bit of humility, that you always got to listen to your patients. And that's the end of the talk, and I'll be glad to answer any questions that anybody has.
You had mentioned about the longevity of a kidney, and what are your thoughts on the new DNA testing to find out about if you have any DNA of the donor in the bloodstream? Do you think that's really going to help the chronic rejection numbers?
Well, I suspect that if the initial hype is validated, that it's a step forward, that it'll give us some idea that there's a problem, and then we need to figure out how we get rid of that so that it doesn't adversely impact long-term. I think it's a work in progress. And I think anything, and my basic feeling is that the most important factors that adversely affect the kidney long-term are, one, the calcineurin, the drugs we give. But I don't think, I suggest that we change that until we figure out another way. And two, I think we give different patients different numbers of nephrons. And I think if we are able to figure out a way to, before we transplant the kidney, make sure that that kidney has, 750,000 to 1 million nephrons rather than less than 250,000, that might be helpful. I think that the other real long-term benefit is figuring out a way to determine whether somebody has clinical operational tolerance. Because if I knew that a patient had clinical operational tolerance early on, and I could get rid of or slowly taper all these medications without any potential adverse impact on the graft, that would be a major, major advance. I think we're there. No, I don't think we're there yet, but I think there's a lot of work being done on this problem.
Well, and I'm sorry that I didn't get to properly introduce you due to a barking dog. but I do want to say, everybody, that Dr. Fine is the reason I'm here today. I landed on his doorstep in 1968 at Children's Hospital, flown in from Las Vegas, and I think we both concur. You said I was the first acute kidney injury patient that you took care of back in 1968.
The youngest patient I ever hemodialyzed. You were about a little over a year of age, I think.
I was 2 years old.
2 years old, but you were small. You were the youngest patient that we had ever acutely hemodialyzed. It was you.
And I feel so humbled because you also put a Scribner shunt in my right leg. And I know from stories that I was told that you weren't quite sure when you took the Scribner shunt out if it would leave a big hole in my leg. And my leg is normal today. It's totally fine. And then I know I gave you a few gray hairs back then about my high blood pressure that ultimately took out my kidneys in 78. And you really went the extra mile, because I know that I wasn't doing well on hemodialysis with acetate, and you were quick to get peritoneal. And peritoneal really did change my life, why I underwent 2 transplants that didn't work, because back then people were like, how did you get so many kidneys? And I'm like, well, you didn't want them that much back then because it was pretty much a crapshoot.
That's true.
But it's been truly miraculous to see how much you've done for the pediatric community. And I know that I owe my life to you, and many people do. So thank you so much for joining us today.
It's my pleasure. And I would like to say that you've contributed 10 times to what my contribution has been to the world of end-stage renal disease in patients. And all of your outreach and all of your contribution has made the lives of patients with end-stage disease much better, and assisted them in dealing with the vicissitudes of a difficult disease.
It's an illness is too demanding if you don't have hope. And I have one question for you, because you were the person on this earth that has known me the longest. Have I always been outspoken?
Well, have you been a pain in the butt? Yes.
Okay, but the pain in the butts live, right?
No. Seriously,
And
you're a survivor because you have the will to live, and you have the desire to do whatever you need to do to make that happen. And the people who are survivors are the ones that never give up. And that's the most important thing in surviving a chronic disease. Never letting it get you down to the point that you give up, because I can tell you from my limited experience, the patients that psychologically give up have the most difficult long-term problems.
Okay.
And those that are optimistic and are moving forward despite lots of problems are the ones that survive forever.
well, and I know we're going to go over a couple minutes, but I just wanted to mention something that you did when I was a child. And I'm very public about this, but my family had alcoholism. I had a very crazy family, active alcoholics. My mom was going through a lot of things. And you came to me, and I remember you saying, Lori, you need to know what medicine you're taking. You need to know how to take your blood pressure. And you gave me the tools to take care of myself. And when we talk about, you have to have something to look forward to get up in the morning. And in a weird way, this is really crazy, but my mom had an illness as well. And I felt like I needed to take care of myself to take care of my mom. And it's a weird little twist, but I think anybody who has children, they have to remember they have to feel valued. They can't always feel like they're the burden to, they need to feel like they're making a difference. And I had a little black dog that needed me. And so all of those things that you can do, because I've done the prom for many years, 23 years. And sometimes I see that parents just do everything for their kids. And when they do everything for them, they don't go up with the self-esteem and the confidence that they can go out and do things. And so I just want to put that little tidbit, but I do remember that you giving me control of, you need to learn this. And I think that's a lesson for all. Teach somebody.
You need to empower your patients.
Exactly. And I mean, I was 8 and I knew what blood pressure medicine I was taking, and you explained it to me. And I think we need to remember that we always have to explain to the person taking the meds why they're taking it. And I'm with you on adherence. I am on the kids all the time. I am a professional pill taker. And I don't know where I got that trait from, but I'm very glad that the kidney community is my family. I mean, I was raised by renal care professionals, and I think a lot of what I do today is a result of the team that was around me. So thank you, Dr. Fine, to your contribution.
Keep doing all the good work that you're doing, and thank you for inviting me.
Thank you. And a shout out to our corporate mission partners for making this happen.